Good morning. Welcome. We're doing our fifth installment of our Resiliency series, and this month we are focusing on healthcare. My name is Rebecca Cooley. I'll be your moderator for today, and I'm airing downtown from the AOS studio. We've enlisted 5 local industry experts to help share their insight on the current COVID-19 crisis, specific to their individual roles, and we're looking forward to hearing their insight. As everyone's well aware, COVID-19 is forever reshaping the traditional care delivery models. Many of those changes were already set in motion, whether it was integration of virtual care, shifts away from a traditional hospital-based site. There's obviously been new considerations with dramatic changes in economic conditions, consumer demands, and current market dynamics. So we're looking forward to addressing this and many more with our experts today. A couple of housekeeping notes. We will be utilizing the chat feature. So if you look at the bottom of your screen, there is a chat. We would love to hear from our audience members at the end of our discussion. If you would like a question specific to a panelist, please include their name, and we will direct that to the end. So with that, I'm going to turn it over to our distinguished panelists, and we'll start with introduction. And Dina, I would love to start with you.
Sure. My name is Dina Salvaggio. I'm a registered nurse. I'm the principal for healthcare consulting at Jacobs. I've been in healthcare for over 30 years, quite a while over 30 years. And my primary focus is ensuring that buildings are built properly, that the functionality for clinicians and the clinical support is there, as well as emergency management and space utilization and process utilization.
Great, thank you. Darren? Darren, would you like to introduce yourself?
Yes, I would. I'm Darren Rozas, Principal Architect for Rozas Ward Architects, and I'm predominantly in charge of the healthcare division of our firm. And over the past 35 years, have been the lead medical planner and lead architect as it relates to major medical projects. And I'm very happy to be on board and look forward to the conversations.
Great, thank you for joining us, Darren. Jacob.
Oop.
Jacob, you're muted.
Got it. Hey, everybody. Good morning. I'm Jacob Corbell, Vice President of Business Development for Cardiovascular Institute of the South. We're a large independent private cardiology practice based in South Louisiana. And my role with CIS is really strategic initiatives, and one of those being virtual medicine. So about 5 years ago, we launched down a virtual strategy that has served our patients well and served our practice well, and really came in handy when the pandemic hit. So happy to be on the panel. Thanks for inviting me.
Thank you. Brandon.
Hello, everyone. Good morning. My name is Brandon Kristol. I'm the Operations Project Manager at Children's Hospital New Orleans. We are a organization that is all about one thing, and that is taking care of kids in Louisiana and the Gulf region. And so I assist with a multitude of things, but primarily making sure that our wonderful and amazing physicians and clinical staff are supported to be able to provide the utmost care for the amazing kids in this area that need it. So thank you for having me. It is it's great to be a guest here.
Thank you, Brandon. And last but certainly not least, Marianne.
Hi, my name is Marianne Grafam. I'm a project manager at Sizeler Thompson Brown, working in the healthcare design group. I have been practicing for the past 20 years. I'm a graduate of Tulane School of Architecture and have worked in Washington State, in Seattle and Tacoma, Washington, and also in Honolulu, Hawaii, and then came back to New Orleans. Since I've been back, I've been with Sizeler for the past 5 years, solely working on healthcare projects, working on various campuses around the New Orleans metro region. Currently, I'm focused on working on projects with UMC and LCMC.
Thank you. And thank you again to all of our panelists for joining us today. So with that, we'll jump right in. Brandon, I'm going to start with you. As we've seen many changes happen with technology and again, reacting to sort of this new crisis that we have in place, is there anything that you found that is actually working that will become sort of an important shift as we enter into what everyone's calling the new normal?
Yeah, I think when you ask the question, is there anything, there's a lot of things, right? I think one of the things that we've experienced at Children's is a pretty rapid adoption of technology in a multitude of areas to allow us to continue to engage the community and care for kids in ways that maybe weren't as traditional as they have been in the past, as well as, just everyday things that happen throughout the hospital. One being the adoption of Zoom. I mean, this was something that was very uncommon. Most of our meetings, if not all of our meetings, were folks packed into a conference room. And now almost all of our meetings are over Zoom and using technology. Another big piece, obviously, is the adoption and utilization of telehealth. That's something that has been around for some time, but has not been something that we utilized probably to the extent that we could have. And so, COVID has accelerated that process, even to the point of designing a lot of our new clinics and spaces in our master campus transformation that's happening currently, to be able to have those sorts of spaces available for the physicians to be able to engage with folks and with the families and their patients in other areas. As Marianne can to attest, her and her team designed the beautiful North Shore Clinic that we have in Covington now, and we have some space designed for that remote medicine purposes out in those areas.
Thank you. And Jacob, I'd love to turn that to you. Brandon had a nice segue with virtual care. CIS was really on the forefront of doing a system-wide virtual care delivery model. If you could share a little bit about maybe how that set you guys up for success and what you'll see moving forward with virtual care.
Yeah, we decided, it was 2014, I think, that we wanted to create a new model where really a way to stand in the shoes of our patients. We built a bunch of patient focus groups and started asking our patients, what do they want out of their healthcare? What do they really need? What would make their life better? And how could they really receive the care when they wanted it? So often in our industry, mistakenly, we always ask the patient to meet us where we are as providers. We never meet the patient where they are. And I think that's a mistake we often make. And I think virtual care allowed us to basically put the care back into the patient's hands and let them receive it when they need it. So things like virtual visits, the idea that let's say a 75-year-old woman who doesn't get around well, that her daughter or son has to leave work to go pick them up, to bring them to a physician's office, to sit in a waiting room for 30 or 45 minutes, roll them back into the patient room, see the doctor, come out, get a huge discharge summary, walk them back, drop mom off, and go back to work. That seems very old to us. And so for us, it was like, what if we could arm the patient with technology and they could just sit in the comfort of their own home and see their cardiologist from their home without all the extra stuff? Amazon solved the friction problem in retail. The idea that now you can consume a good as quickly as you can consume it with Amazon. We said, why can't we do that with healthcare? Why can't we allow our patients to consume their healthcare when they want it, when it's convenient for them? So that was the strategy. And sure enough, when a global pandemic breaks out and the idea of crowds being together or folks traveling and being in close proximity, it naturally fit that strategy. So we did 11,600 virtual visits in the first 30 days of the pandemic. And that's audio and video. And so we were able to quickly move strategically in that direction. And look, it was a big win for our patients because, heart disease is the #1 killer. And the truth is, folks weren't seeking care. They weren't seeking care for their cardiovascular needs. And unfortunately, a lot of folks didn't get the care they needed. And so by doing it virtually, we were able to fill that gap.
I'd like to add on to that too. It's amazing how $202 billion in losses expedite market drivers in healthcare. Telehealth is one of them, and definitely a big one, a big change that is going to change a lot of the way that we do, from privacy to HIPAA concerns to cybersecurity concerns, but also flexibility, adaptability. The materials we use are a new norm, like antimicrobial. So when patients do have to come in, how do we get them in? There's robotics, there's the WHO has hand washing educational kiosks that they really want to use, touchless temperature taking, access permissions that automatically lock doors, not to let people in that don't meet the criteria. I think all of that is going to become our new norm when you do have to be in person. So yeah, totally agree.
Darren, I think you're on mute. It's okay. We'll probably say that a few times today. There we go.
Now, can you hear me?
We can hear you now.
Okay. Yes. I just want to comment on a few things. Maybe a broader picture. I agree with everything that the panelists have said. That's reactionary. But if we could just back up a little bit, I think the overriding pre-COVID would be the trends in healthcare. The way I see it is really centered around the patient. And I think everything that the panelists have mentioned prior to me speaking is based off of patient-centered care and patients first. And what I mean by that is I think prior to COVID, that was the forefront of the changes in healthcare. Patients control their environment, whether it's virtual or physical, having that control, having self-monitoring for cardiology, as Jacob mentioned, that's definitely been in the forefront. Pre-registering at home through your iPad and different devices. I think all of those initiatives pre-COVID were based on the new model of patient-centered care. And what does that mean for the physical environment? I think it means more collaborative spaces. There's a couple of trends in healthcare. The on-stage, off-stage aspect of clinic design is one of them. And then really the integration of consult rooms and de-emphasizing physician offices and having more teaming stations. And sort of the traditional clinic morphing into more of specialized spaces instead of everything being the same, if that makes sense. There's a model out there, Cleveland Clinic, I think, had a model where half of the exam room is a consult room. So when you're in a consult mode, you have a different environment, different furniture, different setup. You're speaking on one-to-one dialogue. It's not necessarily always about the clinic exam experience, but initiatives and direction of moving your patient care forward. So the integration of consult rooms with the exam room model, I think is something that's moving forward. And obviously the on-stage, off-stage is a new trend that is received well by some people, but not by others. I think some models and some organizations still feel that the patient needs to see the collaboration, what's going on the off-stage, behind the scenes, and not just enter an exam room and never really see any of the caregivers and the collaboration that really goes on in a clinic environment. But it is a very popular movement right now. So I think pre-COVID, the trends in healthcare, if you could just summarize in one thing, is what's truly best for the patient-centered care, giving them control how they register, control the throughput process once they get into the clinic. And I think that is still in the forefront. And we mentioned a lot of reactionary things from the other panelists. And I think we have a question later on about what's happening in our reactionary response to COVID. And I think a lot of the telemedicine is really advancing 10 years in a 6-month time frame. Jacob mentioned the 10,000 visits in 1 month. There's another organization that I'm dealing with where they had 3,000 telemedicine visits over the whole course of a year. And likewise, they had 10,000 in the first couple of months since COVID. So I think that is reshaping the whole healthcare delivery system. But at the same time, you will really know the pitfalls. How will the patient actually receive, never seeing their physician one-on-one. And I think certain specialties like cardiology and internal medicine, and a few other ones, telemedicine works even better for those specialties. It's not as much surgical driven outside of cardiology. But I think those were the main drivers pre-COVID. And I think it's all for the benefit of the patient, patient-centered care. And what does that mean?
Yeah, Marianne.
I have a few comments on how COVID is going to change and this period is going to affect life moving forward. I do feel that from the design point of view that I think the biggest change is actually the Zoom meetings themselves. I think part of the design process is collaborative, and it's hard to get the clinicians on board, and having the ease of meeting quickly through a video conference has actually upped the participation from the clinician side to engage more in the design. And I think that's an important part of producing a holistic project at the end. I also feel like the integration of infection control, we always do engage infection control in the process, but that process is usually further back as a review of the project after. I think their input will be more in the forefront. And as we are currently in the thick of things right now, but I do feel like as we evolve, like there will be this hybrid of telemedicine and physical visits. And it's exciting to see what that's going to be, because obviously some people will be more interested in physical visits as well. And there was one other thing, but I'm sure it'll come back to me.
Thank you all. Brandon, did you want to add something?
Yeah, no, I loved what Darren had mentioned and Marianne about, being able to utilize technology to reach places that we never have before is so important. But how do we make sure that we still do that in a way that is authentic and engaging with the patients in our community, and especially working in a pediatrics organization, it is so important. I have young kids myself that, there's a lot of things that worry you when you're a parent and you're bringing your child to the hospital or you need something for a child, and there's a lot of confusion. And it's a balance. The patient experience piece is very real, and I think that's the other side of the coin of how do we do that in a way that is beneficial to our families, but also utilize technology and utilize these new opportunities that we have to still provide a really good patient experience, but not lose that human touch. And so at Children's we have some amazing leadership that really puts some thought into that, and we've also have some great partners with designers and other folks at these various opportunities that we've had over COVID to think through how do we do that really well. And it's evolved. What we did back in April is not what we do now, and I fully anticipate what we're doing now is not what we'll do in December or next year. But I do have a sense that this is, there's not going to be what it was, and it is going to continue to evolve. And I think with that, we just have to continually remind ourselves that we're dealing with people, and people need to have that engagement. And so, I love that you brought that up, Darren.
Jacob, if I could just follow on that, you mentioned we're doing things different today than we were 6 months ago, and we're probably going to do something different 6 months from now. And that's part of that reactionary response that I was alluding to earlier. We don't really have time to vet it much. So as designers, Marianne, you're probably going to run across this as well. I think it's more to the forefront to be flexible to some degree. And, sometimes flexibility in design can be a bad word because it's flexible for a lot of things, but not specific to any one. And we've all run across those, make spaces flexible and how the outcome usually is. How do we adjust to that in this time frame before we know the real results of going 30%, 40% telemedicine in a typical clinic environment? And how does that transform into the clinical stage? So elimination of exam rooms, the traditional 3 exam rooms per provider, does that go away now? Or how do you adjust for the days that you're not doing telemedicine, you're still seeing all your patients, do you still need all the exam rooms? And then when you're not seeing the patients and you're doing virtual, what does that look like? And to try not to overbill. So I think we have to be cautious in our reactionary responses to some of the COVID environment. And I'd like to, Dina, get your response on that, as well as Jacob. You guys seem to be somewhat at the forefront of that, Jacob, in the virtual arena. And are you seeing any pitfalls and seeing any response, other than positive responses from patients? Are there any negative responses?
I wouldn't myself call them negative. I just call it evolutionary. But the responses that we're seeing there's a lot of bricks and mortar, a lot of real estate that people are calling us about, saying, what do we do with this? We don't need it anymore. What do we do? Do we repurpose it? Do we sell it? What do we do? Yeah, and I think the market is moving toward that, because a lot of people say, well, telehealth, yes, it's being reimbursed now, which is one of the reasons it's being reimbursed differently now than it was before. So that has encouraged physicians to accept more telehealth patients. They can see more, they can talk to more, and they don't have to see them face-to-face, safer for everybody. There's also point-of-care devices such as the otoscopes, portable EKGs, digital stethoscopes, that all transmit readings to a physician real time that can be purchased about anywhere. So I don't see it going away. In fact, I see it probably building, which does mean it's going to impact this brick and mortar, especially for outpatient, some outpatient services, and for office visits specifically, because we're seeing a huge amount of that now. And that's just this, but there's also office buildings, typical office buildings. No one's going back to work. Everybody's staying home now on Zoom. So just those are changing as well. So yeah, we're seeing a whole lot of it and being requested to support that a lot.
Interesting.
I think one of the things that we're focusing on, specifically in our specialty, our physicians, if a patient comes to see their cardiologist, the physical exam matters, right? The stethoscope, hearing the heart sounds, the ultrasound of the heart really matters. So I don't think that virtual will ever replace our specialty, but I think what it does is that it gives the patients an option. And I think that's what's been missing in our delivery system forever. There's never been options. It's, well, here's where my office is, and you can come when you can get in. Sorry, it's 3 weeks to get an appointment. That's just how it is in healthcare, and I'm a busy physician, and that's where I think that's what has to improve. And I think what telehealth does is it fills that gap. If you don't have the resources to leave work and come to the clinic and wait that hour and see that doctor, but you can stay at work and you can see the physician virtually, and then schedule maybe the physical exam around your schedule. That's the paradigm shift that I think can transform the delivery system. And I'm with the panel that the in-person patient experience matters, and I don't think that goes away. I do think what this does, though, is it allows the patient the option, and I think that's a game changer. We have seen more patients. So for instance, we talk about Hurricane Laura, okay, and what happened there with some of the evacuees from Lake Charles. The cardiology groups there were shut down. They didn't have power. So we've been seeing patients from our partners and our friends in Lake Charles remotely from Arkansas, from Texas, from Louisiana. And so we've been able to fill a gap via technology that otherwise couldn't have been filled with bricks and mortar. So it's not only has it been COVID, but now the recent hurricane response in our state, we've seen telemedicine play a big role in healthcare.
I think there's always going to be a need for that face-to-face. I don't think that ever goes away. Never. It can't, unless something amazing happens, which doesn't surprise me if it would. But no, that hospital stay, that cardiac cath, that echo, the EP labs, those aren't done at home. But those come back and see me in 3 months is going to be done telehealth, yeah.
And as Jacob had mentioned, I think what you were saying was the patient has more control. More patients centered around the patient And I think that was the number one trend in healthcare starting a few years back, the hospitality, patient control, giving them options. And I think it's coming to fruition right now.
Yeah, and Dina and Darren, I think one of the themes you keep mentioning is flexibility, whether it's flexibility in design or how we're delivering patient care, or how much of our space needs to be virtual versus, inpatient. Are you seeing now maybe a different look at, other ways to build out the space, whether it's from a, manufactured construction approach, or flexibility within the technology that may be used from room to room? Are you seeing any shifts from a design perspective of how do we accommodate sort of these unknowns moving forward?
I can start from my perspective if you want,
Sure.
unless that was specific.
Or Marianne, anyone on the panel. I just
Okay.
y'all both mentioned flexibility a good bit.
Okay.
So,
Well, from my perspective, a lot is going into the front end. As Darren mentioned before, being proactive instead of being reactive. A lot of times we have involved clinicians later in the game, not in that pre-planning stage. So there's a lot of consulting going on in a planning state now from a clinical perspective, understanding specifically how they work. Is it the best processes possible? Are those being incorporated, since more than 90% of a health system spend is on their operational day-to-day functions? How can we really optimize those with the space that we're using? And is it the right place to do? So there's a lot of consulting going on the front end now, where before it was, let's get their input and build it in and just take in what they say and put it in, and it says 8 OR sometimes. There's a much more of that consulting proactively going on, and adaptability of room acuities. Making sure that we don't make the same mistakes we've made before, which was, let's build X number of ICUs and we'll build this number of this level, this acuity level. Now it's more about, let's make acuity adaptable rooms, private rooms that can turn into ICUs when and if we need them. Those types of things. How do we isolate one ward, one floor, so that we can continue doing the elective surgeries and it not impact our revenue? So for me, that's a lot of what I've been involved in, with helping teams understand how that works. How do you switch HVAC digitally immediately to make it negative pressure? Where does that go off the roof so that it doesn't fall down on the poor guy that's, in EVS or in maintenance? Those are the things that we're working with people proactively on, so that they don't have to do that later, or that we learn from the mistakes that we've made in the past.
I would have to concur. Oops, sorry.
Go ahead, Marianne. Go ahead.
I agree with Dina that part of design process is, I think, flexibility. And I think a huge discussion that's going to happen, or is probably currently happening, is the impact of the mechanical systems and HVAC on design. Because beyond the physical, the space, and what we as designers can control regarding finishes and fabrics, the HVAC portion is huge, and making spaces more flexible is, I think, part of the solution. I also feel that the design of hospitals and healthcare systems, it's a long process. Like, we're not designing hospitals every 5 years. So I think flexibility is just innately in the process. And from my experience, we try to design within the code, within FGI, with the flexibility in mind for the future, because we have to know that things that we build today, it has to adapt for maybe 5 years, 10 years, 20 years down the road. And with this pandemic, what I'm excited about is, obviously, IT has been a huge part of the healthcare industry, but I think it's progressively grown, and currently is almost highlighted as one of the departments that are moving forward in this pandemic. And the adaptability of what I enjoy is the adaptability of even exam rooms are flipped over to telemedicine rooms easily with just a video camera. So there are small steps, and I'm sure there's going to be large steps in technology, and also not only the physical space, but all other sections to move healthcare design forward.
If I could chime in a bit, the inpatient environment, I think, is shifting more towards a universal room, like Dina mentioned, and I think COVID exacerbated that a bit. We saw the needs for ventilators and ICU rooms, expanding beyond our capabilities, and as healthcare shifts more to an outpatient environment, and you have the mothership, the tertiary hospital, I think there'll be far and few between where the major big medical institutions offer the full variety of care, but not every community hospital will. And you're seeing that in the market right now. There's a lot of acquisitions going on with the sole intent of feeding the mothership, as I say. But I think the universal room is probably the biggest adjustment. It is already coming into play as well, because having the patient go into a typical med-surg room and then their healthcare diminish a bit, and having to move them to an ICU room and then vice versa back to a med-surg room, that's 2 or 3 moves for one stay. And I think the trend now is to put them in one room. It meets all the physical FDI requirements for all aspects, whether it's ICU, regular med-surg, et cetera, and create a room that the patient can stay in the whole time. The regulatory agencies have to keep up with us. LDH is slowly coming on board with the universal, and as designers and architects and facilitators, we always have a problem with getting LDH to agree with us or any regulatory agency. So I think there's going to be also more flexibility in the way that regulatory agencies look at projects and more receptive to waivers, or maybe we don't have to do all the waivers all the time. So I think the whole industry is morphing, including all aspects of it, regulatory agencies, et cetera. But from an inpatient standpoint, I see the universal room being the norm. I'm not sure why you would go back to a regular med-surg room. OB and other disciplines are a different story, but just regular med-surg, I just don't see that being the typical norm anymore.
If I could add something real quick, one other point, at least that we're seeing, is from a design perspective, legacy healthcare, as we call it, these massive consolidated hospitals and these 10-story buildings with all these floors, and it's become quite expensive. And I think this migration now to outpatient ambulatory surgery centers, Darren's very familiar with the project we have going on right now in Gray, Louisiana, where the patient experience of being able to come in, park in a parking lot, walk into a facility, have your procedure done, and go home that afternoon. We talk about patient-centered care. CMS and the regulatory agencies are really starting to push physicians and hospitals to build more ambulatory procedure areas and give the patient a better experience as it relates to parking, how you come in, when you check in, when you discharge home. And so I think you're going to see, and you've already seen it, right? GI, ortho, those specialties have already been in ambulatory surgery centers. But for the first time ever in 2020, cardiology started entering that space because CMS, Medicare, approved the single vessel stent in an outpatient lab. And so that's going to make a huge shift in our industry. So from a design standpoint, I wouldn't be surprised if over the next 5 to 10 years, your large healthcare systems like an LCMC, they're looking at more smaller scale ambulatory surgery centers as opposed to the traditional large hospital.
Actually, probably Brandon could speak to this as well. That's what I have been seeing as a designer, that historically the number of inpatient beds have diminished over the years, and now for the health of patients, they would like more procedures done outpatiently, in and out in one day. And I'm sure Brandon can speak on that as well.
Yeah, I mean, I think really at the end of the day, you guys are all hitting the nail right on the head from that perspective that, the term brick and mortar keeps coming up. And the reality is as we become more effective and efficient with technology and new products, there's a reality that those brick and mortars, traditional facilities are maybe not needed less, but maybe needed differently. And I think that's the lens that we have to start looking in the future through. So I would agree.
I also think that the other government agencies, Medicare, Medicaid, they have to also get on board with this new direction of more outpatient ASC-driven stuff. Any administrator knows that you do the same procedure in the hospital as you do in the ASC, you get better reimbursements in the hospital. So when is that going to change to really make the ASC the prominent, mechanism for that, the outpatient trend that we're going? But at the same time, hospitals need help as well. So there's a lot that goes into a hospital, and that surgery, that small building that we're building in Gray is a lot different than the mega machine that has to support a lot of things. And I guess that's why they get better reimbursements. But I think this whole trend for the outpatient trend has to go through all avenues. Government agencies get on board, changing reimbursement levels, and other aspects of healthcare delivery besides just the physical.
Thank you, Darren. I know another trend that we've seen in healthcare pre-COVID, I want to get your thoughts on it, is sort of treating a patient holistically, and how can we be more, provide more preventative care services as opposed to sort of that reactionary care service, looking at wellness clinics, really supporting that whole lifestyle from exercise, dietary, mental health, et cetera. Have we seen that pause during this time, or are we going to see an even greater need sort of coming out of COVID hopefully soon?
I can tell you it is accentuated. Being healthy, staying safe, staying apart, being very conscious of contaminants is something that is at everybody's forefront right now. The public's health is very important right now. So the things like those acuity adaptable rooms, isolating a wing to HVAC, disinfectants being used through HVAC that can disinfect for multiple contaminants for 8 to 12 hours now without being redistributed, and they're non-toxic. Those are becoming more and more. Understanding hazards on the hospital side, doing a needs assessment for emergency management, to understand their processes, their hierarchy, the organizational structure, so they respond quickly. They don't have everybody stumbling over each other, which sadly enough happened in some areas where they didn't have a plan. There wasn't preparation. We see a lot of people asking us now to help them create those plans. We have 2 physicians that work with myself at Jacobs, and that's a huge ask, because they're like, we need to know what we're doing. What's our playbook? Do we have enough space? Have we built out enough space for our stockpile of the things that we need once we find out what hazards that we're susceptible to? All of those things are, the robotics help patients feel less anxious and keep them more comfortable, using artificial intelligence, making sure elective surgeries can happen, because they've considered cancer and some heart surgeries as elective. So they were not able to go have what could have been life-saving surgeries during this time. If we plan well enough proactively, we build it, or we retroactively plan for these emergencies or these hazards in existing facilities, patients will feel more comfortable and staff will feel more comfortable. The nurses and the doctors won't be afraid they're going to get it if we plan for enough PPE and we understand what we need in each hazard in a medical emergency or emergency management.
And Dina, simulation centers have become very popular over the past 10 years, and some of that is to aid people like you that want to have a better understanding of how a team in the full operating room environment, how that team works together. And I've been involved with several simulation centers, and that's besides just the competency teaching for the physician itself, which is very important in health sciences. it's also the team effort, how that team works together, some of the things that you mentioned. So simulation has become a big part of educating and planning, as all the things that you mentioned. I'm sure you guys are engaged in some of those practices.
Yeah, absolutely. There's actually software that can be used to track people, I think I mentioned it a little earlier, to track people, track materials, track how close people are, track the throughput. It's live simulation with immediate alerts when people are too close or a room gets too full or any of that. So instead of just doing a simulation where you enter variables and help to understand those throughputs, this is live simulating all the time. That goes to a dashboard and is monitored. I think that's absolutely what's going to happen across healthcare soon.
I also
Helps the
think,
patient.
Yes.
So I also think this, with COVID-19, it highlighted the existing health concerns that people had. And I think that will also speak to how holistic health is going to change. And again, reiterating what was discussed before, but I think holistic health is definitely going to be more on the forefront of discussion moving forward.
And Rebecca, I think a point that you brought up that hasn't been quite touched on specifically yet is just the mental health and well-being of folks, especially in these unusual circumstances we find ourselves in, where a lot of people have experienced long-term isolation, and obviously in the business that we're in, we are about caring for kids, and we have seen unfortunately a dramatic impact on the kids that we care for in that realm of mental health and behavioral health and their well-being, and so that's really interesting to think about. And I think that also dovetails well into the piece of flexibility. These patients that have special circumstances require rooms that may not be the same as an exam room or an ICU room or whatever that may be. And so how do you have these influxes of needs that we potentially may not have the space to be able to care for them? And I know that's something that I've talked to some folks at other pediatric and children's hospitals that are experiencing some of the same growing pains that we are as well in this time. And I think that's something that we have to face the reality that this is really impacting kids in a way that I think is even harder than it is on adults, and they don't know how to emotionally process those things, and it's coming out in ways that it's magnifying things that I think that's been there, but it's becoming a problem. And so how do we think through to care for them as a wholeness, as you had said, Marianne, of health, as opposed to just thinking about their physical ailments and things of that nature?
I think that's a great point, Brandon. We, so often, at least what I see in healthcare is the specialists and they tend to stay in their lane. They don't tend to cross over much. That they may be treating a patient's, GI issues, but if they're depressed and anxious, they're just not going there, and they shouldn't. They're not trained to do that. I think what we've seen, at least again in the cardiology world, is a major shift toward preventative medicine. And look, the regulatory agencies are the ones driving that. One of the most a Class A indication of heart disease is cardiac rehab. This idea that a patient who's had a cardiac event should start exercising. Well, Medicare really doubled and tripled down on that and said, what a patient really needs is exercise and education and nutrition and some mental health pieces. And so kudos to the federal government for jumping in on that, because right now they have tripled the reimbursement for any physician group or hospital that wants to invest in what they call intensive cardiac rehab, where it's cardiac rehab with those additional 36 sessions, and they're taught by social workers. So we have one in Lafayette, and we have a yoga instructor. We've got 75-year-old patients with major cardiac events doing yoga in the middle of the afternoon, and it's life-changing. They're eating better, they're breathing more, They're focusing on their well-being. It's changed the game. And, unfortunately, our ICR shut down during the pandemic. So patients could not receive that care. We were considered a gym. And so a lot of patients reported dipping back into, and you got all this uncertainty, all this anxiety, some folks suffering from depression, plus they just had a heart attack 2 months ago. So every time they feel any chest pain, they go into near panic. And the one place where they have a home and they feel safe and they feel cared for, we couldn't access it. So, not only was it a patient care issue, but look, we had to shut down a full clinic operation for 60 days. It was a financial issue. But I'll just say one last thing. One neat thing we did there, one of the dirt wall solutions that we used that worked really well for us was in our intensive cardiac rehab. We put up a dirt wall and embedded a TV similar to what Rebecca has behind her. And we connected our social workers via telemedicine into that rehab anytime a patient reported depression or anxiety on their cardiac screening. So again, we connected this multidisciplinary team through technology. So we had a patient show up one day and doing her normal intake, right, for her cardiac issues and why she qualified for rehab. She scored a 24 out of 25 on her depression score. So within 10 minutes, we were able to connect a social worker into that intake room and address her depression. As we got her admitted into Lady of the Lords that afternoon, got her into an IOP for behavioral health for her depression treatment while simultaneously in cardiology. And that's where it all needs to go. I mean, because if the depression's not sorted out, nor is her heart failure, it's not going to change. Those two things are symbiotic. So they're not mutually exclusive. So we feel like while we're not going to ask our cardiologists to become therapists, we are going to make sure we have a resource bank where those nurses and doctors can send them to instead of just saying, sorry, we don't treat that.
Absolutely. Well, thank you guys for all of your insight thus far. We did want to take a couple of minutes to allow some of our questions from the audience. If you have not had time to write a question, please fill in the chat. With that, I'll invite Carolyn back to ask a question.
Hi, panelists. This has been incredibly insightful and informative, so thank you so much. The first question that popped up in our chat was for Darren, asking you to elaborate on the on-stage and off-stage concept.
Sure. On-stage, off-stage is really, it's been around for quite some time, but it's mainly in the Western states. But the concept is off-stage is all the back of house, the nurse stations, the support spaces. On-stage is really the access for the patients to individually access an exam room from one side of a corridor and the caregivers on the off-stage access from the other side. Pediatrics, this was a pediatric norm for clinic for a long time, and I think that may be changing a bit. But now it's going into all aspects of clinic to where the patient really never sees the back of house stuff, never sees the collaboration, and that's the downfall of the on-stage, off-stage design is they're not really privileged to what goes on off-stage. They're really addressing the patient flow from reception, registration, to a small waiting room, more like a lounge, and you go directly into an exam room from one door. The physician and caregivers enter from an opposite side, so you really don't see any of the typical clinic space. So in some ways it's more hospitality driven, and in some ways it's a little cut off from the care and being part of the collaboration of the care, and that's really the only negative side to on stage, off stage. The other negative piece to that is the double corridors. Really, it's a space piece, and a lot of institutions don't want to give up the space for the double corridors. And depending on how big the clinic is, they can expand and expand and expand. But from a patient-centered care perspective, where it's really about their experience, I think it's a positive. If that answers your question.
I think it does.
Absolutely. I know that's interesting for many of our listeners that are not as familiar with how healthcare facilities are designed. Our next question is directed to all panelists. Many industries are taking a page from the healthcare industry and looking to experts for direction. What advice do you have concerning health-focused design for the A&D community and clients on the call today?
Carolyn, how are they going to implement that into other industries in like the corporate world?
Yeah, it looks like that's what they're asking.
I think one idea that I was thinking about is probably more of integration of process. Obviously, as designers, we could design a space. For instance, I would have to take the waiting room. It's a large area of congregation, and I think thinking forward, we'll rethink where we have larger spaces where multiple people will congregate. And then we would have to, as hospitals and industry partners or whatnot, you would have to rethink how are you going to process either patients from the waiting room directly to exam rooms to limit congregations of large people. It would also probably speak to larger lobbies in the commercial sector or larger conference rooms, how we rethink that. But I think it's taking into consideration of efficiency of process will be part of the discussion moving forward.
I think there's also, I know we're working with a lot of airports and some public health areas in other countries, just public spaces and expansion of public spaces. And infection control, infection prevention, and a lot of this mitigation of emergency, all of those best practices are now going into that planning and understanding how clients should pass through, how travelers should pass through airports, how people should pass through in public spaces, how to kind of channel those people without actually having lines. To make sure that distances are still good and what kind of materials to use, what kind of air handling to do. So it is not just in healthcare, it is in just about every industry now.
I'm also assuming that I know in healthcare design we talk a lot about cleanability. I'm sure that discussion is carried through all disciplines.
Absolutely. And Carolyn, I think we have time for one more question.
All right. Our final question is a big one. It sounds like, on the one hand, there are some great ideas for how to refit or build new spaces to be more resilient and flexible. But it also seems like the health industry is still reeling financially. So where do the resources come from to implement those technologies?
Brandon, do you maybe want to take a stab at that one? You're the operator.
Yeah, I mean, there's so many layers to that question. I really wouldn't know where to start with that. I mean, I'll punt to Darren and see if anything comes up. He seems like he has something in the hopper.
I just think that you're already seeing it a bit pre-COVID, but I mentioned earlier, you're seeing many more mergers of hospitals. They're developing buying power co-ops to where, if they have 4 or 5 hospitals all buying the same supplies, they get better prices. And I think that's happening, the mergers and co-ops being formed. I think there's a lot, and I'm not an administrator, but I'm seeing that in the work that I do. Dina may have a different insight, but I just think that the concept of the mothership that I mentioned before and streamlining all your specialties into one tertiary hospital, and maybe the community hospitals that are part of that organization are responsible for one aspect. So I think there's ways that they're saving money, buying power, and consolidation of services. Dina, do y'all see?
Yeah, so there's a couple ways that people are affording this. One of them, there is some federal relief money that people are utilizing that you can apply for to get either retrofitted or to buy modular rooms, depending on what you need. Going back to you, Rebecca, whatever you need to manage some of these crises, some of these hazards, some of the responses. There is some federal money that is out there that you can utilize, but also with a full emergency management plan, budgeting is one of the main things for this. So while you may not have it this year in the budget, that is something that's being budgeted in just about every health system's budget for emergency management to address those things. Either the older hospitals, sometimes you can't make those changes as easily as you'd like to, so they're buying rooms or ways to set up modular units. We've been involved in hotel rooms that have been changed for USACE. We've luckily have not been involved in the tents, as they were kind of a failure for what was needed. But we evaluated all these different types of rooms and things that are needed, which ones were financially the best answer and clinically the best answer. I think each facility needs to do that. They need to understand what their options are, and then they need to budget for it, and they need to submit for the federal dollars that are out there.
Yeah, I mean, I would agree with both of what you guys brought up. I mean, I think a lot of it is there are funds out there. I think it's being prepared to how to access those funds, having a sound plan, and engaging people that are going, like Dina mentioned, like engaging subject matter experts that are going to allow you to understand, products that are available, how they best integrate into your hospital and for your staff that is providing care, and coming up with a plan, and also there, a small but practical thing is thinking through process improvement. I mean, as you know, anytime you're working in an organization with several thousand employees, there's so much room for being able to improve processes, which will allow you to capture hopefully some financials to think through how to make things better around the hospital. And that's something that is difficult because there's so many moving parts, but it's necessary. And I think if you can have folks that are able to focus their bandwidth on that and engage people that are capable of assisting in those, a lot of times you do see the benefits of that. Not so much in the short term, but definitely in the long term.
And Brandon, I think that's an excellent point that you bring up, because you can do things that will help your bottom line immediately, just asset relifing, those types of things that change the bottom line. It's an accounting measure. It doesn't take much time to do, but it's a depreciation type of factor that can help with relieving some money in the short term or quickly. A lot of things. Space, process optimization, non-labor expense reduction, workforce optimization, all those things can be done to help relieve some money in a shorter term.
I also think that policy, I think it was mentioned earlier about CMS approving telemarketing or telemedicine in a different way. I think it also relies on the federal government and their funds and how policy changes about reimbursables.
Great. Well, thank you to our questions that came in, to our audience members that submitted those. I think with that, I want to thank all of our panelists for joining us today. I'd love to give everyone an opportunity to maybe give us your last words, maybe a silver lining coming out of this. And we'll start with you, Dina. Oh, you're on mute. Dina, you're on mute.
Thanks. Sorry about that. I think with all things, there is silver lining. All change brings positivity too. Even though there's a lot of negatives, it seems, financially especially, I think there's a lot of things that are positive. We are now experiencing things that we've wanted for years. Telemedicine is one of them. Robotics, automation. We are building emergency plans. We are doing things that are more patient-centric a lot faster than we would have ever been able to do it. The changes in reimbursement models, while they're kind of slow to catch up and it's hurting, they're changing, they're evolving. I think without this novel virus, we would have not been able to get there near as fast.
Darren, do you have any last words for our audience?
Yeah, I think that the whole industry is going more lean, whether it's lean in the way that the patient flows through a clinic or a hospital, and lean in the way that the care is being administered. And I think it's all based around what I mentioned earlier, patient-centered care and patient first. And the lean aspect is more for the caregivers themselves and cutting their travel distance, cutting their processes down to minimal. And I think that's the silver lining, that we're heading in that direction. And I think having choice for the patient is going to be the forefront now. Control of their environment, control of their care, better control. I think it's a silver lining that's going to come out of all this.
Jacob, do you want to add on to that?
Yeah, I'm going to echo what everybody said. In healthcare, we've been talking about going from fee-for-service to value-based care, right? That's been the buzzword for years and years and years. Well, guess what? We're still in fee-for-service. This virus, as Dina said, absolutely sped up that process, and it's a good thing for our industry. This virus will end up being the reimagining of the system that we always needed, but we never had that major event to get us there. And so I think if you're in the space of design and build, to David's question, healthcare will bounce back, and it'll bounce back big. And so while the resources are strapped now, that will not be the case in 2021 or 2022. So if you're out there looking for the next thing, now's the time to be in R&D and figuring out what the solution is, because the demand's going to be there.
Brandon?
Yeah, I'll take a little bit of a different approach. I think during these unusual times for us, one of the things the silver lining that I've seen the most and reminded the most of, and maybe this is because of the community that we find ourselves in, is just the support of the local businesses and the communities around us, and engaging all the various hospitals and really showing up, bringing food, stopping by, helping out, doing whatever they can do to make sure that these folks that are out there working tireless hours, especially when this thing really kicked off in April and May, and just showing up. And I think it was a reminder of how important it is to not lose touch with the community that we are serving, because that's what we are here to do. We are here to care for the community. And it's really easy to look at the business pieces, and it's really easy to look at all the other items that are happening. But at the end of the day, if we lose focus on that, man, we've missed the mark. And it was a humbling and sobering last several months, but it was great to see our community show up and care for the healthcare workers that put in tireless hours out there trying to take care of folks.
Absolutely. And Marianne, any last words?
Yes. I agree with Dina that out of tragedy, there's always like growth and a renewal. I do feel that, the world was different after 9/11 or after Katrina. I think the same thing will be said for COVID-19. What I do like about this in our environment in healthcare is this just sets the stage for, as Jacob said, R&D research. And I think money is being spent on that. I recently read an article about negative pressure helmets that isolate and rethink how we control infectious disease to the individual. And all this innovation and thinking, it would not have come without tragedy, unfortunately. But I feel like it's only going to move the dial of design and better care, better patient care forward.
Absolutely. Well, thank you again to each one of our panelists for taking an hour out of their day today. I know that our audience has benefited just as much as I have from listening to your dialogue. So thank you again, and we hope everyone has a great weekend.
Thank you for having us.
Thanks for having us.
Thank you.